Good morning. Welcome, everybody, to the Fralin Biomedical Research Institute Pioneers in Biomedical Research Seminar Series. This is our first seminar of the year in the post-Groundhog Day epic, and it's a beautiful day here in Roanoke, so we all look forward to this Friday's talk. Before I have the opportunity to turn it over to Dr. Bickle to introduce today's speaker, I just want to remind everybody in the series, the next upcoming lecture will be, of course, next week, next Friday, where we have Dr. Andre Fenton speaking, who's a professor in the Center for Neuroscience at New York University at the Langone Health Center. And he'll be talking about memory, learning to learn, and control of cognitive representations. So I hope to see you all next week as well. It's good to see we have a good group here today. So I will now turn it over to Dr. Warren Bickle, and it's the pleasure of introducing our speaker today, Dr. Alan Budney. Warren?
Good morning, everyone. Thank you for being here. It is a real pleasure to introduce Alan Budney. He's not only a colleague and an occasional collaborator, but my good friend. I've known him for over 30 years in a variety of capacities. Alan is a professor at the Geisel School of Medicine at Dartmouth, where he directs an NIH T32 training program on the science of co-occurring disorders, and is director of the Treatment Development and Evaluation Core of Dartmouth Center for Technology and Behavioral Health, a NIDA P30 Center of Excellence. He got his PhD from Rutgers University, did a postdoc at University of Vermont, and is a licensed psychologist. Dr. Budney's research has been continuously funded since 1993. A large component of his work has focused on the development of innovative behavioral, digital, and pharmacological interventions for cannabis use disorders. He conducted the seminal human laboratory and survey studies characterizing the cannabis withdrawal syndrome, which has resulted in the inclusion of cannabis withdrawal in the most recent version of the Diagnostic and Statistical Manual of the American Psychiatric Association. His work could not be more timely for Virginia, as our governor and legislature are contemplating legalizing marijuana in the upcoming weeks. More recently, his studies have involved the leveraging of social media to understand the impact of changing cannabis laws and regulations, and the development of online applications of behavioral economic interventions to reduce cannabis use and related conditions. Dr. Budney has contributed a lot. He's been president of the two major divisions of the American Psychological Association related to addiction. He was president of the College on Problems of Drug Dependence, the oldest scientific organization studying addiction. And he was also a member of the DSM-5 Substance Use Disorder Working Group and consults with a large variety of scientific organizations. He's published over 175 papers, and I could not be more pleased to introduce him to you. Alan, please take it away.
Uh-oh. I think I lost everybody.
Uh-oh doesn't sound good. We're here.
All right. Okay. Let me just get behind this. Sorry. Thank you, Warren. Let me just get my screen shared. We can see you. Oh, there we go.
Yeah, we see
All
you,
right.
but we don't see your
Yeah.
screen share yet.
Can you see it now? No?
No.
All right. Let me try again. Sorry.
It's okay.
We'll get there.
Why does that keep showing up?
It's the green icon there in the
Yeah.
Zoom app.
Whenever I share it, I get a picture of something else. And I don't know why it's doing that. Slides is virtual background. Share.
I just made you a co-host. Maybe that will clear things up.
Yeah, shoot. Usually this works just fine. You can hear me okay?
Yes, we hear you fine.
Yeah. There's something.
And we see you. We just don't see your screen yet.
All right, let me try this again. All right.
There you go. There you go.
We got it. Yeah, I was on some beta system. Whatever the heck that was. All right, hopefully I can. All right, I think we're ready now.
Yep, looks good.
All right, thanks. Sorry, everybody, but thanks for inviting me. Warren, thanks for the introduction. It's a pleasure to be here. Not well, it'd be more of a pleasure to be there. I did visit Virginia Tech, I don't know, maybe 20 years ago. Bob Stevens from psychology had me down to give a talk. I loved the campus. I was hoping to make it down this time. But anyway, at least we have this. So as Warren said, I'm going to talk about cannabis today. I'm going to talk about my most recent research that has used social media. It's been a new thing for me the last 4 or 5 years. The nice thing is with the pandemic, it hasn't slowed us down at all because everything we've been doing has been remote. So a few disclosures. Warren said I've been funded by NIDA for over 30 years. I've done a little consulting, but nothing now. I've worked with people that are concerned about drug abuse and people that are concerned about cannabis therapeutics. I have one personal bias to put out there. I don't know if it'll come out much during my talk or not, but I'm not a fan of medical marijuana laws or the term medical marijuana. And usually that creeps into my talks, but I'm not sure if I'll try to hold that back a little bit and we might talk about it later. So here's my goals for today. Basically, I want to alert you to, since I know we have a diverse audience, alert you to some contemporary public health and scientific issues related to cannabis use. And by cannabis, marijuana, I'm going to use those synonymously. Then I hope to illustrate how social media can be leveraged to expedite and advance research related to cannabis use, cannabis policy, development of interventions, and many of these methods can be applied to other drugs and other health behaviors. And to illustrate that, I'll provide some snapshots of our work to date in this area. I probably have too much prepared. I'll try not to go too quickly, but hopefully leave some time for some questions. Mostly I want to prompt some thought and interest in both the cannabis issues and the methods that we're using, because I think they can be useful no matter what field you're in. A few acknowledgments to start, so I don't forget at the end. Two major people, Jake Borodowski and Mike Sophis, both former trainees that contributed to a lot of the work I'm going to show you. Then some other trainees I have listed there, as well as NIDA that supplied the funding to do some of this. But as you'll see, a lot of this work has required no real funding except for a few $1,000s here and there that I didn't use really grant support for. All right, so cannabis, contemporary cannabis. As Warren mentioned, the legalization, the cannabis landscape has been changing constantly. Each time I give a talk, I have to grab another one of these maps that you can see here. And right now we're up to 36 states that have medical cannabis laws and 15 states with recreational cannabis laws. And if you have a recreational law, you also have a medical law. So 36 of the states out there have legalized cannabis in one form or another. The laws all differ tremendously. It's kind of fun each time I give a talk somewhere new. I look to see what's going on in the state. And so what I have for you here, let me get this out of my way. What I have for you here is what's going on in Virginia, if you weren't aware. You kind of have a unique situation, relatively unique as far as I could tell, is that usually with cannabis and medical cannabis, there are certain conditions, medical conditions that are stipulated by the your state government that you can potentially get cannabis for. But I think the way the Virginia law writes is all medical conditions can potentially ask for cannabis approval. And so if your doctor thinks cannabis is a drug that can perhaps help you, then you can apply and try to get cannabis. So that's one aspect that's kind of interesting. The other one is right now in Virginia, they don't sell plant-based or buds of cannabis. So they're trying to discourage smoking because smoking is bad. That's similar in a few states, but most states sell buds and flowers. So Virginia has a few unique qualities. I put a few pictures up here for you to see what these products look like if you're not aware. You can see they're sort of attractive. This one these are gummies. They're like gummy bears. They kind of look like lozenges, but they're not. They're gummies. They have 95 milligrams of THC in them. We won't really get into what that means, but it's a decent kick if you took all 95 milligrams. They also sell medicated chocolate that has THC in it, which is the compound in cannabis that gets you high. You can take drops under the tongue. This is called a concentrate that's sometimes called shatter, glass. This is very high potency cannabis. You take a little tiny piece of this to get high. And over here you have oils that I think more recently became available. And they sell them with kind of interesting names. This is Martian Monkey. It's supposed to be a medication sold in a medical dispensary. I'm not really sure why they need to name it Martian monkey, but that kind of gets at the heart of what's, in my opinion, kind of wrong with medicinal marijuana laws. That said, let's move on. Let's try to move on. There we go. Okay, what I'm not going to talk about today is CBD. So I'm sure most of you know, I've heard about cannabidiol. CBD is now being marketed in all kinds of health products. It's thought of as a health supplement. It probably doesn't do much of anything for most things, but it's being sold like crazy. It doesn't get you high. It doesn't have THC in it. We're going to try to stay away from that today. Okay. So cannabis, I think I missed a slide. Yeah. So cannabis is one of those drugs where it's both thought of as an addictive and problematic drug, but also as a therapeutic drug, as we just talked about. And mostly, when you're talking about the addictive properties of cannabis or the problems people may develop with it, we're talking about cannabis that has THC in it. So all my slides the last couple of years, now when they say cannabis, they have THC laden in it. And that's just to indicate that it's the type of cannabis, it's not CBD, it's cannabis that has the compound in it that gets you high. And at this point in our science, clinical science, in every accepted meaning of that concept, cannabis has addictive potential. The science is strong, it's unambiguous, people can argue about it, but in my mind, it's all there. Oops. The therapeutic potential, medicinal benefits of the cannabis plant is all potential and all plausibility. There are a few medical conditions where the evidence is supportive, but for most of what you hear about that cannabis can help for medically, the evidence is very scant if it's there at all. The clinical efficacy for these compounds really is not there. Mostly at this point, a bunch of hype. It is plausible. And what I mean by plausible is biologically we have an endogenous cannabinoid system. There are cannabinoid receptors all over the brain, all throughout your body. And so if you're wondering about addiction, there are CB1 receptors in the brain, and they could hit the reward system here and stimulate dopamine, just like any other drug that's addictive. And then all the other areas and functions of the brain, there's CB1 and CB2 receptors all over the place. And the same in the periphery. A lot of CB2 more than CB1 receptors. So cannabinoids and even exogenous cannabinoids, if you put them in your body, they are going to hit up these receptors and stimulate things going. And so there's possibilities that it affects all these type of things. But possibility, as we know, doesn't necessarily translate into function. So again, just to bring everybody up to speed, why do we worry a little bit, or why can cannabis be a public health problem? Adverse consequences. What do we know about cannabis? We know that it can affect cognitive functioning depending on how much you use and how long you use, both acutely and chronically. It can affect neurodevelopment. Exactly how and how much is not clear, but it's pretty clear it can impact neurodevelopment in potentially negative ways. We know that you can drive intoxicated and increase the probability of accidents, driving, or any other physical thing that's dangerous. Cannabis on board could be problematic. It can impact your mental health. And if you're smoking it or vaping it, it can impact respiratory issues. People have wondered, well, is it really that addictive? How addictive is it compared to other drugs? And this slide just kind of shows you that cannabis, this is the percent of people who become addicted. Basically means do they meet criteria for substance use disorder in the DSM. And you can see cannabis, if you just look at all cannabis users, the addictive potential is lower. In other words, only about 10% of those users go on to develop problems compared to 15% of alcohol. If you talk about people using daily, you're up to about 25% of those probably may develop a problem. The important thing to realize here is that even daily users, you're only at 25% or 30% that have a substance use disorder. So just because you use cannabis, and even if you use it frequently, doesn't mean you necessarily have a problem, just like with alcohol. But there are people that do develop problems and do develop significant problems. And you can see that in our culture because there's plenty of self-help books out there to help people stop if they need to stop. There's Marijuana Anonymous, just like we have Alcohol Anonymous. In the treatment system out there, these are some data from what's called the TEDS data set. These are U.S. treatment admissions, and what you see on these slides, if you look on the left, these are for all teens and adults. What's the primary drug they seek treatment for? And if you look at 2016, the two primary drugs are opiates and alcohol, and cannabis comes in third. This has all to do with the opiate crisis that has had opioids go through the roof. Because if you look back in 2002, the people that sought treatment for cannabis, opioids, cocaine, all about the same percent. But now the opioids has swamped everything. If you look at just kids, you see that cannabis is the #1 drug by a long shot that kids seek treatment for. So people do develop problems with it. Again, not everybody. And this is a slide I've been using for a long time, and I think is a very reasonable way to think of cannabis for everybody, is that cannabis is more similar than dissimilar to other substances that are considered substances of abuse. Like other substances, cannabis is used primarily for its positive and negative reinforcing effects, to feel good or to take bad feelings away. A subset of those who use will develop problems. Most people will not, just like other drugs. And the problems that people develop range from mild to severe. There's basically data to support this, and I think it's just a reasonable way to kind of start a conversation and to think about cannabis in general. Okay, so we're talking about the culture. And so what's the problem with legalization and medicalization of cannabis? What's the potential problems that could happen? One of the major things that can be influenced once you make a drug legal and medicalize it is you change the perception of risks and benefits. And changing perceptions can result in earlier age of initiation, people using more drug, using more frequently. People that wouldn't have used in the first place because they weren't at risk may try it as if they learn that it's lower risk, if there's benefits. There's more peers using, which peers can influence other peers, more use by vulnerable populations. So as it changes its place in culture, you have to worry about how people's perception of the drug changes. And as always, the most vulnerable populations have the highest rates of cannabis use disorder and consequences. So the people most affected usually by these type of changes are people that are in disadvantaged situations, people that already have psychiatric or mental health disorders, people with physical disorders. So these are the people that most likely be impacted. And what's going on, if you're wondering, is risk changing? There's a study called Monitoring the Future that's conducted every year nationally, mostly with high school students, but nowadays they've switched to adults and college students. But what this data illustrates at the bottom, they asked a question, first of all: how much do you think people risk harming themselves physically or in other ways if they smoke marijuana? I underline smoke because I think this is a bad question because people use marijuana in lots of ways. And I don't know if the people that answer the question pay attention to smoke or just use. But anyway, regardless, they give the same question every year. And you can see since 1990, the perceived risk of cannabis use is going down and down and down. So whatever's going on in the country, people are starting to see cannabis as less risky. Why is that important? I always like to throw this slide up. I don't have much time to go over it, but I give lectures to the University of Vermont freshmen every year on cannabis. And I ask them this quick question, and they use their clickers to answer. Do you think cannabis has therapeutic benefit for depression, anxiety, ADHD, PTA? And you can see the percentage that say yes. And that kind of shocked me at first when I thought, well, college students, over 50% have these kind of issues. And so if they think cannabis is good for that, not only do they like to party with cannabis, but now they also think it's good for whatever condition is affecting them. And you can just extrapolate that so that they're at increased risk for developing some problems and using more frequently. So that's how I see cannabis. That's where I think that, in a sense, the public health problems or issues stand. Let's switch over to our work. So leveraging social media. What do I mean by that? Well, let's talk about sampling and data collection, because that's really what it's all about. Jake Bordowski, my ex-graduate student and now colleague, published an article in JMIR in 2018 that kind of describes these procedures in some detail, kind of an interesting kind of tutorial. But pretty much what we do is we capitalize on Facebook and Instagram being ubiquitous social media sites across the US. There's over 200 million people on Facebook. 60% use it every day. They use it for a bunch of minutes each day. So you have access potentially to a lot of people. And so what we've done, or what we did, I don't know, probably 6 years ago now, with a postdoc that showed up and sort of was dabbling with this, is pretty much Facebook allows you to advertise, and you can target your advertising. And so we're trying to advertise to marijuana users. And so we put in, we'd like it to go to people that are interested in normal or high times or marijuana. You just put in these things, and I'll show you about that. And these advertisements show up on their phones or their iPads or their computers, and they say, would you like to be involved in a study? It shows up on their news feed in Facebook. And if they click it, they get sent to our site, our platform, where we can do some research. And so the coolest thing about this is this advertising platform allows you to ask for certain ages, gender, locations. Then you put all these interests in. If you're interested in cannabis, you type in cannabis, medical cannabis, high times, reggae music, Bob Marley. Any way you think that people that'll hit will be interested in cannabis and might be interested in your research. And so lo and behold, we did this, like I said, 6 years ago. And what we were interested in that time, and the people in my lab, graduate students, undergrads, and postdoc, were things about legal cannabis laws, risk factors, and intervention development. That's kind of what's floating around in the lab. And since then, we've conducted over 15 studies using these methods or something similarly. Today, I'm going to show you some data from a few of these, many as I can kind of get through. And this is what really turned me on to this. So this first study, we were interested in vaping primarily, how people use cannabis and whether it's changing. So we kind of had a whole bunch of vaping questions we were wondering about. And using that Facebook advertising platform, in 42 days, we got 3,000 subjects to respond to our survey. It cost us about $800 in advertising. We got better at it. We did a second survey, and in 28 days, we got 2,000 people. And then we were wondering, can we get kids, 14 to 18-year-olds? We got 3,000 in 20 days for only $350. And so if you're a clinical researcher or a human laboratory researcher like me, you're used to having like 10 to 15 people, maybe 90 in a clinical trial, or 120 if you're lucky. And all of a sudden, I can ask questions and get people to do some tasks in the thousands, and it doesn't cost me any money. And so we went on to do all these type of things. I'm going to tell you about some of them. This one I won't mention, but I think I won't be showing you any data, but it was kind of interesting. This one was simply, I had a colleague in San Francisco who was applying for a grant, and she wanted to show that she could get Facebook users interested in treatment, and she could deliver an online treatment. But she didn't have any data that showed that was really feasible, that they were interested. And in 6 days, or in 8 days, we put out some ads, and we got 1,100 cannabis users to write in and answer questions about whether or not they would be interested in a intervention on their from Facebook to do a remote intervention with a Facebook kind of platform. And I don't know, 30% said yes, 20% said maybe, that kind of thing. But she had data for her grant, just like that. And that's the kind of stuff you could do that was kind of cool. A couple of the projects, like this last one here, this was Jake Bordowski's dissertation. He ended up with about 8,000 subjects. It cost more. It cost us almost 5,000. He got all the data in 6 weeks, because he wasn't just looking for cannabis users using the traditional kind of interest that we were using. He wanted to get low-level cannabis users and non-users. So he started advertising it with interests like NPR, people that weren't only interested in cannabis. And so in that way, you see if they're interested in marijuana. It takes a little bit longer and a lot more ads to get enough low-level cannabis users into your project, but you can do it, and it's still not very expensive. So that said, the other cool thing that happened without trying was that we found out that the geographic representation of people that participated in these studies was correlated highly with the geographic population, the population in each state. So probably I think the data are like 0.94 correlation. The number of people from Florida that participate in our studies is proportional to the number of people in Florida in the United States. And remarkably, like 3 or 4 studies, we looked at this data and came out the same. So you get a geographically representative population, which was kind of nice, especially if you're interested in legal cannabis laws. Who answers these typical cannabis ads when you just use the interest that I told you about, normal and things? Well, mostly we get heavy users. 45% say they use every day. If you look at people that use most days, it's up over 60 or 70%. But we do get some lower level users, but not a lot with the usual form of advertising. So let's go into what a couple of these studies look like. So like I said, we're interested in perceived risk and benefits. And this is a picture of my postdoc that just finished up with me, Mike Sophis. And he and an undergrad were interested in perceived risk and this health beliefs models, because how people perceive risks and benefits can help you understand this initiation, escalation, vulnerabilities, helps you know what to target in a prevention or an intervention program. Kind of obvious reasons you might be interested in this. And we looked at that question from the Monitoring the Future that always comes up. We thought that's just a bad question. And that's what everybody uses to gauge how people perceive the risks of cannabis. And so Mike and the undergrad wanted to develop a new perceived risk question or questionnaire and compare this novel measure that assessed both perceived harm and benefit, since benefits are what everybody's talking about with cannabis. And they wanted to compare how people answer these new items to the traditional item used in the Monitoring the Future survey. And so what those 2 items look like is the first one looks like this. How much do people risk harming themselves physically in other ways when we changed use from smoke? And this is the traditional question. And they say they see no risk, great risk, etc. Just a 4-point Likert scale. And the other, the other one, the new question is, what is the likelihood of physical harm or benefit associated with using marijuana daily or almost daily? And instead of just saying risk, slight risk, moderate risk, we created a VAS scale, visual analog scale, where they moved the bar from either minus 100 if they think it's very harmful or 100 if they think it's benefit. So you can get anywhere in there. And when you do that, here's what you get. With the traditional risk question, again with Facebook, we got 1,800 people to do this pretty quickly. And these are asking about the harm with daily use. About over 80% say there's no risk. Then a few say there's slight risk. Even fewer say there's moderate or great risk. So kind of what you saw before. And with these regular users, that's what it looks like. With this novel measure, what it shows us in this first column here, these are the people when they answered the traditional risk question, they said there was no risk. When they do the VAS scale, almost all that no risk becomes benefit. So all these people that said no risk, they tend to respond to benefit. And the people that said there was slight risk, they're also answering in the benefit area, not the risk area at all. So when people are evaluating risk of cannabis use, and you give them the opportunity to think about risk, benefit, and weigh how they evaluate cannabis generally, they're erring on the side of benefit. And so if you don't ask about benefits, all you get is this answer to a risk question. It isn't very informative. And so kind of the summary of that, those people the cannabis users who have previously been discussed as perceiving no risk of harm, they might more accurately, or at least also be described as perceiving great benefit associated with use. So risk benefit is always a ratio, and people evaluate both at the same time typically. So if you're going to evaluate the health beliefs of cannabis users, it seems essential to consider perceived benefit at least as much as perceived risk. and prevention intervention efforts have to address benefits. So it's kind of obvious, but right now perceived risk is basically one item out there in the world of national sampling. So a little more on perceived risk. Jake Borodowski, this is part of his dissertation. He was also interested in perceived risk of driving. For those of you who aren't aware of the literature, there's a pretty strong literature that suggests that cannabis intoxication can impair driving and is related to increased probability of accidents. So there's some argument about this, but it's pretty clear that intoxicated drivers are not safe. So Jake, in his dissertation, I showed you this before, he got 4,000 regular users pretty quickly. And he asked a simple question: how much do you agree or disagree with this question? I can drive safely under the influence of cannabis. And these are these strong users, and I need to move this so I can see what it says. Strongly agree, 23% agree, so almost 50%, 40 to 50% agree that they can drive safely under the influence. So that may shock you or not. It's consistent with what's done in a bunch of other surveys have found similar things. Jake took it one step further. How high could you get and still drive safely, he asked them. And here we have how they rated their intoxication. 10 would be, I'm so high I could puke or something. 0 is not high at all. And this is what percent of the people answered the question this way. Well, if you look at the people who said they could drive at a 6 level and above, it's about 50% total say they could get over a 6 and still drive safely. What does a 6 mean? Who knows? The scale hasn't been validated in any way with amounts of THC, etc. But this is getting probably pretty high and feeling like you could drive safely. The last question then he asked was how high, think about how high you typically get. And in the past 30 days, how many days have you driven a car 2 hours after getting high? And you can see 15% pretty much say every day. And if you get most every day, you're up to about 25%. So we got a lot of regular cannabis users out there on the roads, high on cannabis and driving. So a little alarming, obviously a risk factor that needs to be targeted if we move forward with legalization. I think this is one of the reasons legalization has not moved forward more quickly. We're not sure what to do about intoxicated cannabis driving. But anyway. All right, let's move on to another risk that we've been interested in. This is some research that an actual Dartmouth undergrad has finished up recently. She was very interested in cannabis in pregnancy. And NIDA's director, Nora Volkow, has been hot on this topic and has been presenting data to show that cannabis use in pregnant women has doubled in the last few years. And what we know about cannabis's effects on the newborn, on the birth process, and on the adolescent isn't a lot, but there's certainly a lot of alarming and potential problems that we have some data to worry about. But there's a bunch of perceived benefits during pregnancy. It can help with morning sickness and nausea, stress reduction. So there's all this kind of controversy out there about cannabis and pregnancy. And so Chelsea Pike, the woman running this study, she was interested in applying to our methods. This time she had to target pregnancy in addition to cannabis, so it wasn't as easy to get people. But within a few weeks, she got 300 women, pregnant women who were cannabis users. She also used a $25 raffle prompt to get people to respond. The inclusion criteria were cannabis use prior to pregnancy. And what she got in the sample, as far as their cannabis use status is 121 of them, of these 296, had quit cannabis as soon as they found out they were pregnant. 132 reduced or tried to quit and relapsed, and 43 just continued to use as they had before. Oh, sorry about that. And so what Chelsea looked for were predictors of quitting versus continuing. And continuers, again, were defined as no change after becoming pregnant. And so pre-pregnancy, those that continued were using more cannabis, They had a higher sign of dependency in that they used right as soon as they awoke in the morning. They endorsed more benefits. They had fewer risks. They had greater delayed discounting scores, a sign of impulsivity that we'll get to in a little bit. They endorsed more benefits than the quitters. They scored lower on the risk scale. So everything you would think about that makes sense was true. And this same kind of literature is true in the tobacco use and continuing to smoke tobacco during pregnancy. So it wasn't too surprising, but this is really the first documentation of this in any serious numbers. Chelsea also asked about communications about cannabis with their medical provider. And overall, only 38% communicated at all with their doctor about their cannabis use. And interestingly, the ones that continued, 55% of them actually talked to their doctor about it, and only 25% of the quitters. So maybe the quitters just quit and never mentioned it to their doctor right away. But anyway, more of the continuers talked to them. Interestingly, 50% of the continuers versus almost all the quitters reported that their doctor recommended stopping use. But 42% of the continuers reported that doctors discussed benefits. So doctors do discuss benefits and quitting, so risks, etc., but it varies quite a bit and may have some influence on what women choose to continue to do. If you're curious about what benefits they talk about, women that are pregnant talk about it reducing nausea, stress, improving the ability to sleep, relaxing, helping with back pain. So potential benefits. And so if it's promoted this way, cannabis use among pregnant women could increase as it is, and the potential risk of serious problems with kids now and in the future is there. So this is another area where we need a lot of research, a lot more attention, pay more attention to this problem as well. Let me just check my time here. Okay. I'm going to skip over this. Well, I'm going to go quickly through this adolescent use. We were interested in teens, as I told you before, and the impact of policy on them. But I'm just going to quickly show you a little bit of data because I want to get to the last part of the talk. Pretty much right away with these big data sets, we were wondering if laws affected the ways people used. And we saw with our adults that the longer a state had a cannabis law in place, and the more dispensaries per capita they had, the more likely they had tried alternative methods to smoking like vaping and edibles. And this was true in the adults. So we wanted to see if this is true in the teens. And these data show you the same thing. Longer duration of cannabis laws in your state, more densely populated dispensaries, and you get more vaporizing and edible use. And whether that's good or bad is not the question, but it does influence how people use cannabis. So that's important to know for policymaking. We were also wondering whether vaping is replacing smoking as a more common method among youth, because youth were all, this is about 2016, youth were all talking about vaping all the time. But when we ran this study, and this is 2,600 youth, we found that smoking was still the first route of administration that they ever tried. 34% tried it as a second route of administration, but smoking still swamped things even back then, which surprised us a little bit. We combined data sets to look to see what the preferred route of cannabis use was among people that tried all three. So if you tried smoking, vaping, and eating or edibles from marijuana, which did you prefer? We thought, again, vaping would bounce up there, but still smoking, for whatever reason, still the preferred route of both adults and adolescents. Vaping at 9 or 12%, we didn't know quite what to think about that because we didn't have a baseline for this. More recently, a new student, Ray Sue, was interested in this topic, and I don't have time to show you this, but the thing to recognize, one, we have much fewer people for a number of reasons, but the first route of administration in this young group of people, only 65% smoking was the first route, and in that previous study, which was done in 2016, 4 years earlier, it was 94%. So more people were experiencing vaping or edibles as their first route of administration. So things are changing if this data holds. This isn't a very big number. The other thing interesting was that smoking, people that started off smoking, about 25% switched to vaping within 18 months. Some vaping, though, people that are vapors also switched to smoking. So I'm not quite sure what to make about that. But anyway, it's cool to see what you can do with these methods and get data pretty quickly. All right, this is the last thing well, there's two things, but one of the major things I want to talk to you about. This is some work that Mike Sophus brought to our lab. He was interested in transdiagnostic risk factors and interventions. And the two that people are interested in this area are delayed discounting, or what's called temporal discounting, and anxiety sensitivity. I'm not going to talk about anxiety sensitivity today because we don't have time. But delayed discounting, I'm sure a lot of you know what this is, but the brief and quick definition: delayed discounting is the degree to which a reward loses its value as a function of the delay to its receipt. So if you don't get your $100 for 6 months, it's not as valuable to you now. And it's kind of thought of as a form of impulsivity, the tendency to devalue the future, and hence make choices and decisions that reflect this, that you're more a here and now kind of person. And Dr. Bickle and his colleagues have studied this extensively, as have many others. And people that have high discountings tend to choose smaller, sooner rewards over larger, delayed rewards. And we've learned how to measure that in an individual difference variable. You have a behavioral task that titrates both the time and the magnitude of the reward. And you can get a K, and a K is somebody's discounting rate. So if you have a high K, you're a high discounter. And what we've learned over time now is that these K values relate strongly to addictive substance use and misuse. So lots and lots of data that Warren and many colleagues have collected, that discounting seems to be a ubiquitous risk factor or a vulnerability factor for substance use and other types of negative health behavior. With cannabis, the literature hasn't been so clear. A recent review suggested that the relationship between cannabis use and discounting appears smaller than for other substances. And they think it might have something to do with it. People don't perceive the risk of cannabis to be harmful to your future. So it makes sense that discounting wasn't as related to cannabis as something like tobacco or perhaps alcohol. Well, Mike Sophus was very interested in this. He ran one of our Facebook studies. You can see the data down here, and it looked pretty clear in this first relatively large data set, by far the largest data set looking at a drug and delayed discounting scores, that cannabis frequency and severity moderated the relationship between discounting and cannabis. So as the review had kind of alluded to, the people that are high frequent or perhaps problematic cannabis users, they're more likely to be impacted by discounting. So discounting has its effect. You see it in the people that are problematic users. So given that, Mike and I have been interested in something called episodic future thinking, which is an intervention that, again, Dr. Bickle and colleagues and a number of people prior to that have been interested in as a way to target this vulnerability factor called discounting, delayed discounting. And it's a way that people propose that you can enhance the valuation of the future. And so the way episodic future thinking works, it's supposed to guide the creation of hypothetical personal future events. You get people to kind of envision future events and focus on them for a brief period of time by writing down what the events are in detail. And there's a bunch of data out there that shows it can reduce discounting nicotine and alcohol in people with obesity. A few studies have showed that it mediates the effect between EFT and reduction in substance use. There's not a lot of data on that. But there's been no research on the effects of this EFT in cannabis. And so Mike took this on. We took this on using our online strategies. We didn't use Facebook this time. We went to an MTurk platform because on Facebook, if you're going to pay people piecemeal, you get a problem with bots. Lots of bots get in there and try to get your money. You have to pay people to do this because it takes a longer time than a quick survey. And so, anyway, we'll talk about that later, but we recruited 200 people through MTurk, a lot of them with cannabis use disorder. We randomized them to get EFT, just one session of this EFT, where they're asked to envision events 1 day, 1 week, 1 month, 3 months into the future. Compared them with a control condition that envisions events that happened yesterday at various time periods. And you measure manipulation checks, how enjoyable, important, etc. the events were once they wrote about them, etc. And we measured discounting. And we also measured readiness to change cannabis use. And in this first study, Mike found that EFT looked like it elicited better event ratings than EFT, and it reduced delayed discounting. So just like with the other drugs that have been tested, it looks like this may also have an impact with cannabis users. We also asked about readiness to change cannabis use, and it looked like going through an EFT intervention, this one-session intervention online, seemed to perhaps increase people's interest or readiness to change their cannabis use more so than the control condition. So Mike designed a second study, and there's a lot of complexity to this, but I'm going to go over pretty quickly, again, because we're going to run out of time. But he had 3 questions in mind. He wanted to enhance the impact on discounting by making the future events that they imagined more positive and salient. So he tried to enhance EFT with a procedure he called domain specificity, where he had them envision specific things to in specific domains, like think about something that's a leisure activity, that's a social activity, that's a health activity. And the traditional EFT doesn't do that. It just says envision a positive event. And so he was wondering if the enhanced EFT could show greater reductions in discounting. It might also show reductions in cannabis use. And the reason Mike proposed this comes from the literature on episodic memory that shows that cannabis use is a pretty important risk factor for reduction in episodic memory. And episodic memory is a process that helps you actually envision the future. And so he thought adding this domain specificity to the EFT procedure might make things even more potent. Basically, quickly, 90 subjects randomly assigned to get the enhanced EFT, the EFT or a control condition. We also had people go through what's called an episodic specificity induction training prior to going through each of these intervention conditions. This was to try to again enhance their ability to envision the positive events. And we'll talk. I don't have time to talk much about that today, but those who are interested, there's something very interesting about this ESI procedure that we'll get to in a minute. And then we were hoping to do structural equation model to see if we can show effects on cannabis use with the EFT procedure, but also show that delayed discounting function as a mediator. So changes in discounting are what produce changes in cannabis use. That's the idea behind the study. So what did we find? Well, we found that the enhanced EFT and traditional EFT did not differ in the way that the manipulation worked. They all had better ratings than the control condition, but they didn't differ between the two, so they were pretty comparable. No differences in change in delayed discounting between any of the 3 conditions. Discounting came down in all 3 conditions. This was very surprising and kind of leaves us wondering about a lot of things. But so discounting came down in all 3, so you can't test mediation because it was the same in all 3 conditions. What we did find is that the enhanced EFT condition reduced cannabis relative to the control condition, but it was not different than the traditional EFT. They didn't differ from each other, but the enhanced one did work a little bit better compared to the control group, both in reducing grams of use and changes in days of use of cannabis. So it seemed to show some potential. So the conclusion is pretty clearly it didn't improve quality ratings. Both EFT procedures reduced DD, but so did the control. So it's hard to say what was going on there. We think this episodic specificity induction that I mentioned may have muddied up the findings. And I don't have time to talk about that today, but we've got a paper out there trying to explain it, and I'm happy to talk to anybody who wants to talk about that later. And I'm going to skip through that. The next study in this series is to try to do repeated sessions across 6 weeks of episodic future thinking. From a clinical perspective, if you think episodic future thinking can really change discounting and change behavior like cannabis use, it makes sense to us that repeated administrations over time rather than just one session will work. And Mike has programmed this and found a way to deliver it remotely over the internet again but also we're recruiting through Facebook and Instagram to enhance the generality. We've got a beta test of this done. We're able to recruit subjects without the bot problem. We got people through, half the people through all the sessions. So it looks promising. Problem is Mike has moved on from his postdoc, so I need somebody to come run this study. Last thing to mention, just briefly, what I'm actually in a sense most passionate about right now is I got a new R01 to develop a cannabis consumption index, which may not sound very exciting, but it's necessary for the field. We need to figure out what's low versus high risk patterns of cannabis use, because unlike alcohol, we are actually clueless about how much or what patterns of cannabis use are safe or low risk. And here we are legalizing this product, both medically and now recreationally. We have no idea about how to even quantify how much people are using. So all fields need this. Epidemiologists, economists, clinical researchers, clinicians, health educators, without being able to specify how much, what patterns of use are problematic, it is hard to do any kind of educational measurement of change, provide guidelines for treatment, for prevention, etc. We need this data desperately. Now, it may sound like, what's so hard about this? Well, what we have to figure out is how to quantify all these crazy products that are for sale. There are buds, there are oils, there are butter, there's sodas. There's a million different ways that cannabis is being marketed and sold. And so it's hard to know, both for the consumer and even through the sales agent, how much people are buying, how much they're using per session. And so we're hoping to use these social media methods to collect over 15,000 samples from cannabis users, where we develop a personalized digital survey that lets us collect detailed information about their use, both quantity, frequency, types of products, etc., and also collect validators. So through use of things like latent class analysis, we can identify patterns of cannabis use, specific patterns like, for example, I've written here, frequent daily use with low-level intoxication or low THC quantities might be a profile of therapeutic use or just evening stress reduction like a glass of wine and be basically low risk. So you could be a daily user with low risk. Right now, as soon as somebody mentions daily use of cannabis, they say, oh, he's got to be a pothead and be a problematic user, but not necessarily. Frequent user gets really high every day, consumes a lot of cannabis, would be at high risk. And we're looking to find all those different patterns in a sample of 15,000 people and figure out how they relate to the validators. So that's what I'm up to, hopefully, for the next 3 years, and I'm excited about. And let me kind of finish there with some strengths and limitations. You know, this is obviously not the here-all and end-all, but what this methodology lets you do is get large and diverse samples and target hard-to-reach groups. And so get data on things that we've been unable to study with decent numbers for a long time. It does introduce sampling bias. They are only people that are on social media sites that are willing to do this. They're doing it for free most of the time, so it's cost-effective. The cool thing is you can do it rapidly. You can repeat a survey and change one item. You can do the same survey 6 months later. All these things can happen with this. You do have to limit your surveys to short periods of time, because if it's going to be for free, you can't get much of their attention before they just knock off. I think there's a lot of potential for this application to other drugs and other health behaviors, but they might not be as easy to recruit as cannabis users who seem to love to talk about themselves and tell you about cannabis. And it's a great way to generate pilot data, whether it's for neuroscience, behavioral science, cognitive science. You can ask some quick questions in a population and stimulate some ideas for further exploration, whatever science you're doing. So with that, this is basically one tool for the research toolbox in the addiction world and the health behavior world. It excites me because we get so much data and so much fun, but things will move slowly. I think this moves things a little faster. Science goes, at a snail's pace, but with social media, I think we can learn some things a little quicker. And with that, thank you for listening. Sorry to go so quickly. I know I had a little too much, but I'm happy to answer some questions.
Thanks, Alan, for a very interesting talk. Um, uh,
I like
um, any questions, please add them to the chat and I will read them to Alan. So Alan, there's several questions about this method and the validity of the sample. Are people biased to want to represent marijuana as a very positive thing? What do you think?
Yeah, that's a good question. I would say in general, if you're just using marijuana users, if you're sampling marijuana users, they are generally biased towards saying positive things about marijuana. But is the population we're looking for. Now, are there some, but you'll notice they do say some negative things. So yes, it is in a sense a bias, but no different bias than you'd get sampling marijuana users in other ways necessarily, although we don't know that for sure. But online subjects, you do have to be careful of some things, and we take some steps to make sure, we're getting, quote, real people, people that pay attention to the questions. So there's always some skewing. I don't know if it's misrepresentation. Some of these samples, you could say if you recruited in a different way, and I didn't show you an example of that, but for example, we looked at chronic pain, cannabis, and opioid use. And in recruiting that population, with one Facebook message, we just targeted cannabis users and tried to find chronic pain patients within that population. And then we had another messaging or advertising campaign where we went to the chronic pain population and tried to find marijuana users. And we looked at their data, they were very different. But combining them gives you a more representational view of chronic pain patients that are using marijuana and opiates. So depending on how you sample, you do get some different results, and it's important to pay attention to that.
Beautiful. So one question was driving under the influence. Is that proportion that you see there, is that materially different than we might see with alcohol?
That's a good question. I think I looked that up a long time ago, and I don't remember what I found. I'm getting old, so I don't know. I imagine it is not, because people are willing to say they cannot drive intoxicated. Cannabis users, I think, again, this kind of gets back to that first question. They're not as impaired as alcohol users, but they are impaired. So it's, if you ask the question the same way, you have to equate the intoxication scale somehow. And so it's hard to do a direct comparison, but it's a good thing to think about. And I don't really know the answer.
Very good. So with the EFT results, one person asks, did you look at whether it shifted risks and benefits interpretation of cannabis?
No, we have not tried that. Again, you have a limited time with them when you're doing these online things and not really paying much. So no, I don't believe we collected that in those studies. It's quite possible Mike may have snuck it in there. Sometimes I ask him, he says, oh no, we have that data. But I don't think we asked that in those EFT studies. But that's a good idea. It certainly could.
And what about the presence of comorbidities in marijuana samples? Is there some evidence about what other factors may be contributing to other health conditions?
There's definitely a lot of comorbidity in cannabis users, just like every other substance use disorder. There's a decent amount of depression, anxiety, PTSD, etc. So I'm not quite sure what's meant by how is it contributing to other problems, but certainly when you think about substance use disorders generally, it's people that have other vulnerabilities that are more likely to get into problematic substance use. And so it's not just the drug itself, it is the context that the drug is used in that make people vulnerable. The drug has some potential of its own that's either higher or lower, but it interacts with the people that use it, and that's what determines whether there's a problem. So I don't know if that quite answers it, but you have just as much comorbidity as you have with other substances.
I think, Warren, if I can jump in, I think what Anthony was asking there is a delayed discounting test. If you bring into the context of the questions what those people's conditions are, like if they're diabetic, et cetera, if that's going to change those things.
I got you. Yeah, in those studies we don't rule out everything that could influence delayed discounting, but we try to control for the factors that are known, like tobacco use and alcohol use. But there's always some new things that come up that seem to be related to discounting that you should control for that we haven't. But we do try to control in all those studies for those type of things. I think my thought on discounting in cannabis users, again, is it goes back to that thought with from the review that since cannabis isn't thought of as a drug that with many people that impairs your future, it doesn't cause harm, discounting you wouldn't think would relate to it as much, where it's very clear that the population knows that tobacco causes harm and still chooses to do it. So where you see it is when it gets excessive, I think more people would agree that it causes harm. And that's where the people with higher discounting rates, you would see them amongst the more severe and high frequent cannabis users. And so it's always a difficult thing to explain, but I think I once saw some data from China where they really don't perceive tobacco use. It's not part of the culture that tobacco is really harmful and causes cancer. It's not common knowledge, or it's not commonly thought of that way. And the discounting rates with tobacco in China with tobacco users are not the same as they are in the United States. And maybe, again, this perception of harm determines who does that certain behavior. And that interacts with the discounting finding.
Beautiful. Alan, we got time for just one last question. What do you think the impact of COVID is doing to marijuana use?
I haven't seen any good data on it, but I assume it's doing the same thing as other substances. It's increasing it a little bit. I think, whoever was using is using, and probably, I would assume, using a little more. The context is set for that. There's less other activity going on, so there's more isolation. I would think it's higher. There's no reason to think it wouldn't be.
Great. Well, thank you very much for a very interesting talk. Thanks, everyone.